How are risks to your patient's health determined? Risk as reported in cohort and case control studies. So how do you interpret the results of studies on health risk? In a previous presentation, interpreting the success of a treatment approach, much of what we discussed was the use of an intervention to reduce the risk of an event such as heart attack, stroke, back pain, etc. That risk reduction is actually an association that is determined in the study between the intervention and the event. It could also be that an association could be studied by looking at exposure to a risk factor such as smoking, hypertension, obesity, etc. So, how are those studied? Well, for studies of risk factors versus interventions, there are two approaches, both observational. One is the cohort or prospective study, which follows people through time, or the case control retrospective study, where researchers use a method of looking back over time at those with the problem to determine if they were exposed to the risk factor. In cohort studies, the familiar statistic relative risk is determined. In the retrospective study, a different statistic is used, the odds ratio. So again, with the prospective study, you begin with disease-free people and see who develops the disease when exposed to a risk factor. Whereas, in a retrospective case control study, the individuals already have the disease, and you're looking back, often through their medical records, to see how many of them were exposed to the risk factor. There's a very important difference between these two approaches. In the prospective cohort study, the item of interest is the outcome. Who exposed to the risk factor develops the outcome, versus the case control retrospective study where the item of interest is the risk factor, because we already know which individuals have the disease. Look at the study's stated p-value and/or confidence intervals. What does a p-value indicate? It is the mathematical caution flag that indicates whether to proceed or not based on the study's accepted tolerance of whether the differences found are due to chance. A p-value of 0.05, which is often used, basically says that the researchers and you are comfortable with the possibility that these findings could occur 5% of the time by chance. Stated another way, you can be 95% sure that the findings are not due to chance. So what about confidence intervals? Well, they keep everyone honest about the range of findings in a study. The point value, such as relative risk, is a mean or average of all study participants, but clearly there is a range of findings in any sample of people. And just like the p-value, a 95% confidence interval means that the true value is likely to be in that range 95% of the time, and that conversely, you can accept that 5% of the time it is not. The confidence interval is one step closer to giving you confidence in the clinical significance of the findings. What is our clue that the range conflicts with the conclusion that there is a risk? If the ratio of the event being studied, the disease or the condition, is the same in both groups, numerically they will equal 1, meaning if the event occurred in, let's say, 10 out of 100 patients in one group and the same in the other, dividing them into each other equals 1. If the range of the confidence interval is 1, we know there's no difference, but if it's below 1, we must consider the possibility that this is not a risk factor, or at least in some patients it's not, and at the extreme may be protective, especially if all the values were below 1. So let's use an example. Hypothetically, what if you were studying the effect of diabetes during pregnancy on the fetus and subsequently wanted to determine the effect on abnormal weight gain as a child? This is a prospective study forward in time, and hopefully that cohort of exposed fetuses, those that had mothers with diabetes, is compared to a group of fetuses whose mothers did not have diabetes. Here is how that would be constructed in a 2x2 table. Note that the outcome of interest, the condition, would be abnormal weight gain, and it's our focus. We then compare those fetuses exposed to a diabetic mother versus those that were not, to determine the risk of abnormal weight gain. Let's say that each sample group had 1,000 study subjects. Well, you can see quickly that the rate of abnormal weight gain is higher in those fetuses born to diabetic mothers compared to those who were not. However, you also see that the overall problem being studied, abnormal weight gain, is very low. Although we can say the absolute risk is low, the relative risk or risk ratio calculated by dividing the risk of those exposed by those that were not is high at 10. Well, said another way, children born to diabetic mothers have 10 times the risk of abnormal weight gain compared to those not born to diabetic mothers in our hypothetical study. That was our hypothetical example. But let's use a real study that illustrates a hybrid where patients were studied prospectively but then evaluated as a follow-up retrospectively for the relationship between cardiovascular risk factors and having a diagnosis of lumbar disc herniation. Note that this is not a cause and effect study, but a study of associated risk. This is a key limitation of studies that look back in time. This is a 16-year follow-up study of almost 3,000 nurses. Multivariate analysis was used, meaning statistically an attempt to tease out overlap among factors is incorporated so that there is some confidence that the factor's independent association to the outcome, in this case disc herniation, is estimated. Among the cardiovascular risk factors evaluated were diabetes, hypertension, high cholesterol, and smoking. Here's a table that pulls out the relative risk and their associated 95% confidence intervals for several of these cardiovascular risk factors. You can see the adjusted relative risk is above 1, which indicates a clear indication of increased associated risk. Looking at the confidence intervals, you can see that none fall below 1, which means the range of values in this study population always indicates an increased risk. Also, the p-value is well within the 0.05 target. Well, how could this be stated to a patient? As a diabetic, there's an associated risk of disc herniation that is 52% higher than for people who don't have diabetes, or, even though it may not seem obvious, having or being hypertensive increases the associated risk for disc herniation by 25%. Well, as a side, the proposed mechanism is that there's an associated acceleration of atherosclerotic blockage of the blood supply to the disc in those with these cardiovascular risk factors. In a case control study, we're interested to see who with the disease was exposed to the risk factor. Of course, looking back, especially through medical records, is a shorter, cheaper approach. But because patients cannot be randomized, as in a cohort study, you can only look at an association, not a cause and effect relationship. You can see that what has changed is our focus of interest, which is the risk factor. That's because we already know who has the disease. What we don't know is who with that disease or disorder was exposed to the risk factor. Well, that changes our 2x2 table. Because researchers are able to choose the number of patients they study in a retrospective study, we can only estimate risk through the odds ratio. This is the ratio of odds between those who have the disorder and were exposed to the risk factor divided by those without the disease who were exposed to the risk factor. Let's plug in some numbers and see how this works. Let's say this is a hypothetical study of workers with carpal tunnel syndrome who use computers, the risk factor. You can see here that the odds in those with carpal tunnel, the cases, who were exposed to the risk factor, computer use, is 9, whereas the risk of those in the no carpal tunnel group but exposed to computer use is only 0.82. The ratio equals 11. For our hypothetical study, this could be stated as the associated risk between computer use and carpal tunnel syndrome in our study is 11 times higher than those without carpal tunnel syndrome. Let's explore the meaning of the odds ratio. In both groups, if they have equal odds, meaning the denominator and numerator are the same, numerically this will calculate to 1, which means there's no difference in associated risk. But remember, if it's below 1, it may indicate either a decreased risk or protection. Here are some examples of how you might state the results of a study on risk. Let's now use a real study of risk association in a case control study by Cassidy et al. This was a measurement of association between visits to a chiropractor or MD's office prior to a vertebral basilar stroke. We can see that the odds ratios are all above 1, which indicates some association for both visits to a chiropractor or MD's office and vertebral basilar stroke. Note, though, that the confidence intervals are all above 1 and are rather tight, except for visits to a primary care practitioner, or medical doctor in this case, for patients under the age of 45. So let's review some summary take-home points about studies that evaluate risk. First, they can be forward in time, called a prospective cohort study, or backwards in time, called a retrospective case control study. Although both may estimate odds ratios, case controls can only use odds ratios because the actual relative risk cannot be determined. This is because the sample of patients in each group are not necessarily equal. In case control studies, the researchers can choose the number of patients and who the controls are. Next, if there's no difference between the groups being studied, the relative risk or odds ratio will equal 1. Always look for the corresponding confidence interval to see if the range goes below 1 or in studies of protective factors goes above 1, in which case you will have some doubt about the significance of the difference in groups. Understand that cause and effect may be implied in a prospective study, especially if it's a randomized controlled trial. However, a case control study can only estimate associated risk through the odds ratio. In discussing lifestyle changes with your patients, you should include the literature conclusions on the potential protective effect of diet, exercise, treatment, etc. on their general health and for specific conditions and complaints. Review the literature also for strategies on getting patients to adhere to these changes. But first, convince them with science that this is worth the effort. Note that the article mentioned earlier in this presentation on cardiovascular risk factors and disc herniation appears in the Spine Journal in 2006.